great honor to be here to share with you about TB financing project we do in China. A lot of our work in China with Prof. Tang's team has been centered around TB because it's a really important thing. So for the Gates project, we are working on TB control and financing. For the new Sustainable Development Goal project, we will also pay some special attention to the issue of tuberculosis control in China. So hope through this talk, I'm going to give you some idea of the type of research we do in China. So I'm going to give you some background introduction and then introduce the China Gates TB project, and then tell you what our evaluation objectives are, the methods, results, discussion, and our future research. So why we choose to study tuberculosis? Tuberculosis is the top infectious disease killer worldwide, particularly in low and middle income countries. So if you look at this chart from the WHO, so here it says the top 10 causes of death in low and middle income countries in 2012, and tuberculosis ranks number 9 killer. So for those of you who are not familiar with TB, so TB is caused by a bacterium, Mycobacterium tuberculosis. It mostly affects the lung, but can also affect other organs as well. It spreads through the air. You may not realize, but actually a third of the world's population have latent TB, meaning a third of the world's population have been infected by the Mycobacterium tuberculosis. But luckily, most of us do not develop the disease, even if infected by the bacterium. So in 2014, over 9 million people worldwide fell ill with TB, and 1.5 million of patients died from TB. And over 95% of these cases and deaths are in developing countries. So it's really a big problem for those developing countries. And you probably realize TB is closely associated with poverty. So people who are poor, have weak immune system, and poor nutrition are more likely to develop TB symptoms. And TB, on the other hand, can drive people into poverty because the treatments are quite expensive. So what's the situation of TB control in China now? So if we rank the countries with the highest disease burden, from the highest to the lowest, China ranked number 3. We used to be number 2, but now we're number 3. So the first two are India and Indonesia, and China is number 3. So China currently have around 5 million TB patients, and about 1 million new cases every year, which is a lot of people. If we look at the amount of money we spend in TB control each year, it's around 5 billion Chinese yuan, which is almost 0.8 billion US dollars. So that's a lot of money spent on TB treatment. However, if we look at the TB trends in China in the past 5 years, so here it plots the case number each year, and then the case detection rate each year. You can see it's going down, but it's really slow. So we don't see a huge decrease in the TB epidemics in the past 5 years, which kind of tells our system may have some challenges and issues in effectively control TB. Moreover, we have a geographic imbalance in the distribution of TB in China. So if you look at this distribution where we plotted the 3 areas in China, so there's an eastern region, a central region, and a west region. You can see the green bar. Most of the cases are actually in the west. So if you look at this graph, which tells the urban-rural distribution, you can find most of our TB patients are in the rural areas. So the TB burden is much higher in the west region and in rural areas. So now I'm going to introduce to you the China TB service delivery system and the financing system before I highlight what are the current issues with the system. So here is our old model of TB care. So this started in 1980s. So the feature of this model is that it's centered around CDC, the Center for Disease Control and Prevention. So suppose this is a county in rural China. Most counties will have a CDC, and the CDC is in charge of TB diagnosis, TB treatment, and TB management. And the hospitals are not really doing a lot of work in TB diagnosis and treatment at that time. But gradually we realized there's a problem because in CDC, they don't have enough clinical capacity to properly diagnose and treat some complex cases. And also, some TB patients may require hospitalization, but CDC does not really have hospital beds, so they can't accept inpatients. So gradually we switched to a new model of TB delivery, which is centered around the TB designated hospitals. So in most counties in China, there's at least one county general hospital that's appointed as the TB designated hospitals, and only these TB designated hospitals can do TB diagnosis, TB treatment, and TB reporting in the public health system. And CDC no longer do the diagnosis and treatment. So the main role would be to coordinate the care and do patient management and then do supervision and education. And all the other healthcare institutions, once they see a TB suspect, they will refer to the TB designated hospitals. And once the patients get appropriate treatment in the hospital, and once they go back home, the primary care doctors, it can be the community health center doctors or the village doctors, will be responsible to monitor the patients, to supervise the medication, to ensure medication adherence. But the TB designated hospitals is really a key component in this model. So now it comes to the TB financing system. So there are multiple sources of financing for TB care in China. So the first one is the government-funded free diagnosis and treatment programs. So the central government will put some money to do the basic diagnosis and treatments. So this include the pap smear, the X-ray, the smear test, the smear test, and then the X-ray test. It also fund the standard short course treatment with the first line anti-TB drugs recommended by the WHO. And the second line drugs are not covered under this free program. So the other major source of funding is the 3 medical insurance schemes. So some of you may know in China there are 3 basic health insurance programs, one for the urban employee, one for the urban residents, and then one for the rural residents. So these 3 basic insurance schemes will be able to reimburse some of the TB treatment services if the services are on the reimbursement list. But unluckily, some treatments are not on the list, so they will not reimburse. And another feature of the reimbursement by health insurance is that they emphasize a lot on inpatient services. So if the TB patient gets hospitalized, it will get reimbursed. But the outpatient reimbursement is not great. So if a patient chooses to do outpatient treatment, just to do regular visit to the outpatient clinic, the reimbursement is not good, which I will highlight later. It's actually not a very good incentive in the system. So we also have a safety net program. It's called the Medical Financial Assistance. So this is funded by the Ministry of Civil Affairs to help the low-income households. So it's not particular to TB patients, but they just help those low-income households, low-income patients to pay some of their out-of-pocket costs after the insurance reimbursement. There are also some other government funding or donor funding. So China used to receive a lot of money from the Global Fund, but that's ending. So this part is dropping. So there are some issues in the TB control system in China. So the first one is there's suboptimal patient detection, diagnosis, and patient management. So based on epidemiology, National Epidemiology Survey on TB in 2010, they found that about 10% of the patients are actually undiscovered. So they have the disease, but they don't know, and it's undiscovered. And the traditional diagnostic tests that we use, they are pretty slow to get the results, and sometimes they are not sensitive or specific enough. And it's really difficult to detect MDR TB. So the traditional way of detecting the MDR TB requires about 2 months. So they have to culture the bacterium and then do a drug susceptibility test. That takes a very long time, which means within this waiting period, the patients cannot really receive the appropriate treatment. And even among those who initiated treatment, the termination rate is quite high. So almost 30% of patients will terminate their treatment before they should. So that's also a reason why we don't see very good results in TB control. So the second biggest issue is about the financial burden. So even though there's a free government-funded program and there are insurance reimbursement, but studies found that people still have quite high medical costs. So the average treatment cost for TB, you can see it's a very broad range here, and sometimes it can go really high. If we quantify this to the household income, so on average, patients spend 42% to over 100% of their income in TB treatment, which is a significant burden to these patients. So what causes the high financial burden despite our free program and our insurance reimbursement? So the first cause is because the high treatment cost due to overtreatment and unnecessary treatment, which I will talk about later. So the second cause is the low reimbursement rates by the insurance schemes. So as I mentioned, they only reimburse those on their list. So if the TB treatment is not on the list, they will not reimburse. So it turns out there's currently there are a lot of costs that's not covered under the insurance. And the third one is insufficient medical assistance. And the fourth one is high transport and food expenditure. So a lot of the TB patients living in the rural area, they need to take a bus, take some transport to the designated hospital to receive treatment. And TB is kind of a long-term treatment. For the normal TB, it probably takes 6 to 8 months to complete the treatment. For the drug-resistant TB, it takes 24 months, 2 years to complete. So if patients visit the hospital frequently, there's a lot of costs related to the transport. And for the food part, because a lot of TB patients have poor nutrition, so during their treatment period, they need to, they usually spend additional money to improve their nutrition, and that comes at other cost. So this is also a barrier to their treatment adherence. So what are the consequences of high financial burden? So if it's really expensive, some patients will drop out from treatment because they can't afford it. And if treatment is terminated, that have negative impact on the treatment outcomes. So if the patient does not complete the 6 months of treatment recommended, he may relapse later on. And if it's relapse cases, he's more likely to develop drug resistance. So it's actually quite a bad situation. So the other consequence is that there's the use of healthcare resources are just not efficient. So just now we talked about the overtreatment and unnecessary treatment is a cause of the high financial burden. So what are the common types of overtreatment or unnecessary treatment? The standard diagnosis of TB requires a chest X-ray, but in hospitals sometimes they replace the very cheap chest X-ray test with a CT scan, which you all know is more expensive. But there's really not much additional benefit to the CT. So the other way they do is to use second-line anti-TB drugs, even when there's no diagnostic evidence. So actually, the WHO recommended 4 first-line drugs, And with the combination of the 4 first-line drugs, most patients should be cured. However, in some TB designated hospitals in China, doctors just switch to second-line drugs or start on second-line drugs in the first place. So the other thing we see is that the hospital admission rate among TB patients in China is very high. So in some places, almost all TB patients get hospitalized. So the WHO recommend outpatient treatment. Remember the 6 months chemotherapy thing? So basically, it recommends to use outpatient treatment most of the times, and for those really complex or severe cases, can get inpatient treatment. But in some regions in China, the hospitalization rate is really high, and we all know hospitalization is really expensive. So that's also a way to increase the cost. So the last thing is about the liver protection drugs. So for those TB patients, when they take the anti-TB medications, a common side effect is liver injury. So it's bad for the liver. But usually the recommendation is to take liver protection drugs if there's a sign of, if there's a need. But in China, some doctors, they prescribe liver protection drugs for preventive purposes, which is quite rare, and there's no clinical evidence to support that. But all these liver protection drugs or second-line anti-TB drugs, CT scans, and hospital admissions, they are quite expensive. So all those cost high healthcare costs. So why do they do that? It has to do with, we think it's hospitals' profit-driven behavior, and it's related to the perverse incentive in our payment system. So currently, the health insurance schemes, they reimburse hospitals on a fee-for-service basis, which means they look at how much service the hospital provide and then reimburse each service. So that means the more service you provide, the more expensive service you provide, you get more reimbursement. And that kind of encourages the hospitals and doctors to provide some expensive services. So the consequences, the adverse consequences of these behaviors is quite obvious. So one is have really high treatment cost, and the two is inappropriate use of second-line drugs may lead to drug resistance. So to address all these issues currently exist in the China TB control and financing system, the China Gates TB program was started. So it was started in 2009. It's funded by the Bill and Melinda Gates Foundation, and they signed a contract with, you can see from this photo, so this is our Minister of Health, and this is Mr. Bill Gates. So they signed the contract in 2009 to implement this China Gates TB program in China. And China CDC is the institution to implement this program mostly. So there's a few objectives of this program. So the first one is to improve TB case detection because the current detection is not suboptimal. And the second one is to improve treatment completion rate and treatment outcomes. The third one is to reduce patients' financial burden, which is what we are focusing on in this project. And then the fourth one is to strengthen the effectiveness of the TB delivery system. So here, the China Gates TB program have 3 phases so far. So it started in 2009 to 2012. And the main purpose of this is to evaluate the effectiveness of some tools. It's like a proof of concept kind of thing. And after they found these tools to be effective, they started phase 2 in 2012, is to implement these new strategies and models in 3 cities in China, and know how that goes in the real implementation process and what are the challenges and issues. So for these 2 phases, they invested $33 million US. And now phase 2 has been completed last year, and this year we started on phase 3, which is to scale up the successful models in the previous 2 phases to 3 provinces in China, and investment is $17 million US. So for Duke and Duke Kunshan, so Prof. Tang's team got 700K grants to evaluate phase 2, and then a 1.2 million grant to evaluate phase 3. So today I'm going to talk about the results we got from the phase 2. So here it's a brief overview of what the China Gates TB program is. What are the key interventions? So they divide that into 3 major domains. The first domain is to use some new tools and technologies to technical strategies to improve the diagnosis, treatment, and patient management. And the second one is to improve the service delivery system to enhance the collaboration between CDC, TB designated hospitals, and the primary care institutions for patient care and management. And the third component is to look at the financing and payment system. And the purpose is to reduce catastrophic expenditure. And there's a very detailed approach, which I can talk about later. So here I'm going to talk about the finance and interventions which our team was doing the evaluation on. So as we mentioned earlier, there's a multi-source financing to TB in China, and then the first one is to the reimbursement by the 3 major basic health insurance schemes. So they have negotiated with the local health insurance agencies and changed the policy. So you can see here is before the program, what's going on there, and here is after the program, what happens to TB patients' reimbursement. So you can see before the program, the insurance schemes do reimburse inpatient services, hospitalizations, but the outpatient services, like the normal clinic visits, the reimbursement rate is very low. As we mentioned, this is bad because by doing this, you actually encourage people to go to hospital, to get hospitalized. So what the Gates program did is, so the health insurance now reimburse both inpatient and outpatient services. You can see there's a huge increase for the outpatient part. So previously it's very low reimbursement. Now they reimburse 70 to 90% of the cost. And why there's a range here is because in 3 different cities, based on their local socioeconomic status and the budget of the health insurance agencies, they agreed on different numbers, but the range is roughly here. And for inpatient services, they also increase the reimbursement rate in some places for a little bit. So the second source is the medical financial assistance program, which is our safety net. So before the program, it only covers the qualified low-income households, but with the effort of this program, they start to cover MDR TB patients and normal TB patients above the age of 65. So those elderly TB patients and MDR TB patients can also get some medical financial assistance, even though they don't qualify as low-income households. So the third component is to give transportation and food allowance for those TB patients, and previously there's no. And after the program, they're giving 60 to 130 Chinese yuan per month during the course of treatment. And they actually gave it after the patients completed a few months of treatment, is to motivate them to do their follow-up visit, and then they will be able to get this money. So just now we talked about the financing part. Now it's the payment part. I split this into inpatient services and outpatient services. So previously, before the program, we were using a fee-for-service, which does not really have a payment standard, so just based on the actual bill, the hospital charge. But after the program, they implemented a case-based payment and have set a payment standard of between 5,000 yuan to 9,000 yuan. So this means no matter how much a patient actually spend, the patient, him or herself, and the insurance agency is to reimburse this fixed amount to the hospital. So suppose we set the standard at 5,000 yuan, and a hospital charge 10,000 yuan, and the insurance agency is only going to reimburse based on 5,000 instead of the actual bill of 10,000. And this gives the hospital incentives to really try to control the cost, because if they overspend, they are running at a loss. They will not be able to get that reimbursed. So for outpatient, is also a payment standard is set, and you can see it's actually quite high, close to, it's a few $1,000s, which based on the estimation, so the experts think this is sufficient for the outpatient treatment. So by doing this, they actually try to encourage the use of outpatient services and hope that will reduce the hospitalization rate. So this program was implemented in 3 cities, Zhenjiang, Yichang, and Hanzhong. So Zhenjiang is in the east, and Yichang is in the central China, and Hanzhong is in western China. So you can see these 3 cities are quite different in terms of their population, in terms of their GDP. So Zhenjiang is the richest, followed by Yichang, and then Hanzhong is kind of a poor place. So the idea of choosing 3 different places in 3 different regions to see how the program works in different contexts. And 6 partner universities conducted the evaluation and then did the field work data collection. So you have Duke Kunshan, and then China CDC, and then Nanjing Medical University, Huazhong University of Science and Technology, and then Xi'an Jiao Tong University. So here comes our evaluation questions. So our first question is, does the innovative financing and payment model we described just now improve patients' service utilization, their treatment adherence, and their satisfaction? So our hypotheses are that the program will improve their outpatient service utilization due to more generous reimbursement policy for outpatient services, and therefore their treatment adherence should improve, and satisfaction should also improve. So the second question we ask is, does the innovative finance and payment model reduce patients' financial burden? And the hypothesis is yes. The third is, does the program effects differ across income groups? So why we care about that is TB patients tend to be poor patients, tend to be poor population. And among the TB patients, there are the very, very poor group. So we want to see if our program can actually help these people. So to do the evaluation, we conducted patient surveys to ask about their service utilization, their cost, and satisfaction. So we did a baseline survey before the program starts in 2012, and the sample size is 797. And in 2014, we did a final evaluation and again did the same survey with this number of people. And all those people are randomly sampled from the China CDC's TB information management system, which basically includes most of the TB patients in China. And the survey completed by a face-to-face interview. So in addition to the survey, we also conducted some qualitative interviews with government officers, with doctors and patients to get to know what they think. And we actually also collected some routine data from hospital, from CDC, and from the health insurance database. But today, I'm going to focus on the survey results. So here are some photos of the field work. So this is doing a focus group discussion with patients in the ward. And this is to do a face-to-face interview to complete the survey, and our meeting and doing the survey again. So how do we evaluate the program effects? We basically just compare the changes, just look at the changes in key indicators from baseline to final evaluation, and we look at the effects by different income groups. So these are the set of indicators we look at. And to look at the income, to look at if the program has differential impacts on different income groups, we divided our sample into 3 income groups. So here we use the World Bank's poverty line, which is about this 4,000 over Chinese yuan. So we use this to define the different income groups. So the first group is below poverty line, the really poor, the 1 to 3 times poverty line, which are the middle group, and then above 3 times poverty line, the highest group. And we did some analysis here. We did some descriptive and statistics, and we also ran some regression to look at the significance, statistical significance of the program effects, and if there's any differential program effects on the different income groups. And we did a fixed effect model to control for the time-invariant heterogeneity. So basically, in the regression, we put in the income groups, the before and after intervention, and the interaction before this, and the fixed effect. So we also plotted the concentration curve, which is something quite commonly used in equity research to visualize the relationship between income and OOP expenditure, to see if it's the rich people who have high OOP expenditure, or if it's the poor people who have high out-of-pocket expenditure. So here I'm showing the sample characteristics. So you can see that most of the, if we compare the baseline with the final, the characteristics are pretty comparable, but just note that our final evaluation, this sample, have a higher percentage of people who lives below the poverty line compared to the baseline. So we're actually having more really poor patients in our final evaluation sample. So here is our first set of indicator. We want to look at the utilization of inpatient and outpatient services by income group. So you have the 3 incomes group here, and then the total here, and here are the indicators for baseline and final. I highlighted some statistically significant and interesting findings in red here. So if we look at hospital admission rate, we find overall all 3 groups have quite a significant increase in their hospital admission rate, and the increase is the highest among this middle income group. When we look at the average number of hospital admissions, so count how many times the patient have been admitted, so we find that there's a decrease in all the 3 groups, especially in the 2 or lower income groups. So this decrease means after we implement the program, people are less likely to have a readmission after the first admission. So remember, we have the case-based payment, which just pay them a fixed amount. If they spend, if they do another hospitalization, maybe they will overspend, and then the hospital have to be responsible for that part. So that incentivizes hospitals to try not to have another admission if that's not really necessary. So here, the average number of hospital readmissions, there's also a decrease, which shows the same thing. And here is the average number of outpatient visits in the entire 6 to 8 months of treatment. And we found there's an increase in number of outpatient visits from 4.8 to 5.6 on average. And the increase is larger in those lower income groups. So probably these 2 groups, they are very poor. So previously, with very little insurance reimbursements, they don't really want to go for outpatient care. But with the reimbursement policy now, they are more likely to go to outpatient clinics to follow up their treatment. So here are the results on patients' treatment adherence. So we can see that compared to the baseline, our final the treatment adherence results looks really good. So over 90% of patients have good medication adherence, and the increase is huge in this middle income group. So even though we don't really have a long-term treatment outcome, good outcome measure here, but good medication adherence have been strongly correlated with good treatment outcome. So I think that's a good thing. So here we look at patients' satisfaction, and you can see after the program there's a big increase here. This is for the satisfaction with treatment outcomes. So that means after the program, people are significantly more satisfied with their treatment outcomes, whereas the satisfaction with the reimbursement also increased, but just a little bit. So here it comes to out-of-pocket expenditure. So we get some counterintuitive findings here. So we increase the reimbursement rate, but still, if you look at the trend, at the final evaluation, the out-of-pocket expenditure is actually higher than in the baseline, and particularly in the low and this middle income groups. So if we only look at the direct medical costs, we get an increase. If we look at the direct plus indirect medical costs, we also see an increase. So we'll explain this part later. So we also did calculated two indicators. Sometimes people call this the catastrophic expenditure. So here basically we look at the medical cost as a percentage of their annual household income, and we listed the percentage of percentage of patients with this ratio is about 40% of their income or about 10% of their income, and you can find that this ratio increased after the program, and the increase is bigger in those low and middle income groups. And so here is basically showing the same thing as the concentration index here. So on this axis is the cumulative share of income. So poor patient will be here, and the rich one will be somewhere here. And this is the cumulative share of out-of-pocket expenditure. So you can see the blue line is before the intervention. So before the intervention, poor people tend to spend less than the rich people. But after the intervention, which is the red line, it's about the same. It's close to this line of equity, which means after the intervention, poor people and rich people have quite similar out-of-pocket expenditure. So just to summarize the findings, so we found the program has improved the access to outpatient services in all groups, especially in the very poor patients groups. This is likely to due to the increased insurance coverage, which encouraged them to go for outpatient care. Similarly, we see a similar trend in inpatient service utilization. It also increased, and particularly among the very poor group that we have seen. We didn't really see a substitution between the outpatient service and inpatient service. I guess one reason is because in the payment scheme, they have a package, have a standard for inpatient and another package for outpatient. So that's not a very good incentive to shift people from inpatient care to outpatient care. But the case-based payment had positive effects in reducing readmissions because it really incentivized hospitals to control their costs and prevent unnecessary and really expensive readmissions. In terms of adherence, it improves in all groups and improved the most in the middle income group. So we don't see such a huge increase in the poorest group. So probably besides money, there are also other factors, other barriers, other difficulties that these very poor people face to really have good medication adherence. Probably they don't have enough knowledge, or they need more help with the medication supervision. But when we look at their satisfaction, it did increase in all groups. When it comes to the OOP and the percentage of patients with catastrophic expenditure, it's kind of tricky because it increased in all groups after the program, especially more among the poor. So we think that improved coverage by the insurance schemes and the medical financial assistance is offset by the increased service utilization and therefore the high cost. So if you use more service, even though I reimburse at a higher rate, probably the out-of-pocket payment the patient pays is still going to increase because of the increased service utilization. But remember, this is coupled to the improved medication adherence and improved treatment outcomes. So in that sense, this is not necessarily a bad thing. It's actually good. So also we realized that in the final evaluation sample, we have higher proportion of patients in the really in the lowest income group. So we actually see a change in the patient characteristics that may also infer that after this program, some really poor patients who previously could not afford treatment can now get treatment in the evaluation. But because these are really poor people, so we tend to see a higher rate of catastrophic expenditure. So the other reason of high OOP and high expenditure is that even with the case-based payment we implemented in this program, some treatments were excluded from the reimbursement because they are not on the insurance reimbursement list. So in some places they decided not to reimburse that, whereas in other cities they just reimburse that as well. So there's also a huge heterogeneity in the way different places implement their policies, because that largely results from a negotiation between the program office and the local institutions. So based on the findings, we want to make a few recommendations. So first, we think this financing and payment new model, it did significantly improve the access to care and the treatment adherence. Therefore, it's good to be scaled up and generalized to other places. So when people talk about TB care and control, when they improve the technical capacity, it's also really important to take care of the financial burden part, to really encourage patients to have better access to healthcare. So the second one is this is really a recommendation or a lesson we got from this study. So we find it important to combine the inpatient payment package and the outpatient payment package into one, in a way that they can decide how they want to allocate that. So if we just put it into one and hospitalization is more expensive, maybe hospitals will just substitute inpatient services with outpatient services, which will result in overall cost saving. So the third one is that during our field work and talk to those doctors, actually we find it really important to link medical professionals' income with the implementation of case-based payment. So some of you may have heard that. So in China, doctors' salary is related to their service volume and their prescription, the bill size. So in that sense, you kind of encourage people to prescribe more and more expensive things in order to make more money. However, if we implement the case-based payment, we not only want to do this with the hospital, we also want to do it with the doctors. So if a doctor really implements the clinical treatment pathways, follow the guidelines, and try to control costs, there should be some compensation for the doctor to reward their good behaviors. So we think these are the key lessons we learned from the phase 2 of the study. So this study also have a few limitations. So as you can see, we are using the patient survey data, and when you ask patients about their income, about their expenditure, there might be some recall bias or inaccuracies. So that's something we have in mind, and then we also collected some routine data, like say patient's medical record or billing data, and try to also look at the same issue from using other data sources. So the second limitation is that there's not a very good long-term treatment outcome measure that we have. but we think medication adherence is really closely associated with outcomes. So for future research, as I mentioned just now, we have already started phase 3 of the program, which is to modify the program, the models based on the experiences we get in phase 2, and implement this scale up in three provinces in China. And then again, we're going to do a program evaluation in the 3 provinces to see what are the problems when you try to scale it up, and how you can make some generalizable lessons in case we want to implement this nationwide in the future. That's it. Thank you.